One of the interesting challenges we have, you heard in Jean's presentation about the demonstration project, it'll be 3 years, but CMS has said they'll pull the plug in a year and a half if it's not achieving the goals. And so one of your points was short duration of the studies so far. One first question for you would be, how long do you think, and Lee and Chris, in your work, I think for the three of you, how long do you think you need to really tell whether it's making an impact? What's a legitimate amount of time? You want to comment, three of you? Any one of the three of you?
We routinely ask that question to people, and there was a range of perspectives, but a consistent was a year or two. It was going to be required to get it in place.
Yeah.
Then what would the outcomes be that follow might be another year or two. Although many reflected that this is going to be a continuous evolution and an ongoing process improvement, and as we learn more about what we really mean by medical home, there's going to be more things we need to learn about how we do it correctly.
I think the fairly sharp differences we saw in where people were starting from suggest that there isn't one answer to that question. For some practices that are already thinking that way, that already work that way, a year or two, getting pieces in place, etc. Other practices, first you've got to overcome that management style. You've got to get people working as a team. You've got to change toward a more facilitative style of communication. That takes a lot of facilitation, a lot of determination, and a lot of learning. I think you're looking at a longer timeline for some of those practices.
That's good. Jeff, you want to do a final?
I agree with both Lee and Chris's comments on this, and I think, as I alluded to in my remarks, I think if you really believe that the patient should be a partner in all of this, I think that's going to be the hardest nut to crack here, is really, because you're really faced with a situation of overcoming years of socialization and roles that put individual patients in a subordinate position to physicians. And we're talking about a fairly broad sea change to change that role, and I suspect that it's not going to happen overnight. So all the internal components of PCMH can be in place, but that patient involvement, patient engagement, I think, is really going to be the most difficult one to achieve. You
want to come? Yeah. Go ahead.
I think it's a little bit like saying, how long is it going to take to get a patient to stop smoking? And it's behavior change. And so I think to some extent you can have all the evidence in the world, and you're going to have some patients who are ready, and it's not going to take very long at all. And then there's other patients who are never going to quit. And so creating that environment in which you can build the internal capacity for those practices that want to, are willing, or ready to change, and the market environment and policy environment that allows them to change, I think is kind of the best we can do. I think some practices will retire, will go out of business, will merge, will do other things, and never come to this. But I think that, and just to comment on the Kaiser Permanente, when they were trying to implement their email your physician kind of thing, they had email, everybody had email, all the providers had email addresses, and they could not get uptake. They could not get the providers and the patients to email each other, and they had the system all in place. And what they ended up doing was they started to send notices to the patients saying, email your doctor, ask your doctor for their email address. And so it was actually the patient in that case that catalyzed the change. Because suddenly they had 100% uptake, because the patients all went to their doctors saying, oh, can I have your email address? I'm going to email you. And once that was available. So I think that it's, again, no simple answer.
Yeah, but we have a lot of impatient employers and payers who want to see a quick change. So it's going to be, I think, part of the challenge of this. So we have a ton of wonderful questions, really, and it's very exciting to see the level of questions here, because clearly this panel has stimulated some really deep thinking. I know we're not going to get to answer all of them here. We will I promise you, right, we're going to put answers. It means you guys are going to have to respond in writing. We'll put answers up on our website for them all. You do. You have homework.
More important than that, we didn't proclaim to have any answers.
But you will. We'll make them up. But I do want to try to get through as many as we can here. Save you guys time from writing. We'll capture the answers then. So if you're brief, that would be really good on the responses. Help us move along here. So picking up on this last discussion, we have several questions about the role of the patients. in the PCMH. And, Jeff, I think a couple of people referenced the patients, but we haven't really talked about what your views are on the role of the patients. So, maybe Diane, David, Jean, you might want to start with, and then, the others of you too comment a little bit. Where do you see the patient fitting in this? How do you incentivize patients? What's their role? Whoever wants to start.
So I mentioned briefly that benefit design in insurance needs to include a recognition that the patient is part of this dance. And so the hope is that we're going to be able to put into the marketplace insurance products that include a dimension focused on the patient, the extent to which the patient's engaged with the medical home. The patient will have financial incentives to take responsibility. To the extent to which the patient is going outside of the medical home, the patient will be paying extra. So that's one dimension. The patient-provider agreement that I mentioned, I think, does catalyze a lot of different thinking in a different tone and character and content to the relationship. So that's been important. It's already in place. And then the self-management support element is really important because the extent to which the practice incorporates care management, that's good. So it's core to the medical home model. But self-management is also, it's sort of a sister to care management. And it's a way of getting nurses, social workers, nutritionists, pharmacists, et cetera, to engage actively with the patient, to train them to take ownership of their own health care, care management, and so forth. So I think that it is an evolving set of relationships that will play out in a pretty positive way.
So I think one of the things we really need to focus on in order to make this work is patients have to perceive that there's value in our services. And you think about how you can make an airline reservation at midnight and pick your seat, and yet you can call for days to try to get in to see your doctor. Patients will go elsewhere for health care advice. It's much easier to surf the net and get advice than to get it from us. And I think, as Dave mentioned, the self-management support, I think one of the things that we have not been good at is we tell patients what to do, and we don't listen to what they feel like they need to do. And so I think that one of the important facets of this is really listening to our patients and giving them, because they're our customers. They're not just, we hate to use the term customers with patients, but that's what they are. So I think that will help engage the patients in this model.
I think also just to remember that there are many different patients. Again, I don't want to go and say there's many different answers to every question, but there are many different patients, and I think the analogy to like going to a restaurant where there are people who go to a restaurant and they want the best seat in the restaurant, which is actually in the kitchen, and they want to know who the chef is, and they want to know what ingredients are going into their meal, and they want to see it happen, and they really want to have an in-depth understanding of how that meal was made and how it got to them, and that's part of that experience for them. There are other people who go to restaurants and simply want to be able to find something tasty and affordable, and they don't really care about all the rest of that. And I think that there are that patients are that way too. I think there are patients who want to know some of the behind-the-scenes integration. They want to know they've got a medical home. They want to know what their options are. They want to be able to look on the internet and choose how many stars, whatever. There are other patients who simply want easy access to a place where they can get, where they're not feeling like they're in a chaotic place, and they just want care. So I think that it's it's hard to say exactly the perfect system when there's so many different people that we're designing this for.
Jeff.
Well, I know I mentioned this earlier, but I think this is a fundamentally important issue, and it does stem with, or back to the traditional role of the patient vis-a-vis the provider. So the providing incentives for changing patient behavior, I think is fine, but in order to kind of shift those roles, which I think is fundamentally at the heart of this, it's going to take sort of a multi-pronged intervention. It's changing not only patient behavior vis-a-vis the provider, but also the provider behavior vis-a-vis the patient. In other words, it has to be sort of a systemic intervention to really shift those role relationships in a way to activate the patient as in a meaningful way.
Right. That's
Let me
great.
just give an example, just to reframe it from you have diabetes, we want you to help work on your A1C, fixing, the test, and then you're going to live longer. Ask the patient what matters to the patient. What is the patient's goal? The goal might be, I want to get to my granddaughter's graduation. okay, how can we help you, empower you to change things so that you can do that? And that's a way of engaging people in a very fundamentally different way.
Thank you. I do think some in the audience had the idea, though, that patients need accountability and responsibility in a slightly different way. It's not just about designing systems that are responsive to patients, but it's about making patients accountable for using those systems appropriately. And I think that's a tough one to get at.
Now you upset me. So I get
it's my goal.
Idea. Yeah, it's always your goal, but I get the idea, and I just think there's too much of a blame the victim quality to that line of thinking. Yeah. Somebody who's morbidly obese, somebody who's addicted to X, Y, or Z. There's all sorts of other elements, genetic, environmental, beyond their control than just personal behaviors.
Yeah.
And so when you start saying, you're going to pay more if you don't do X, that it becomes punitive in my view. Better to work on a population.
Yeah. It's going to be interesting, though, because I think, as you well know, many employers have a good percentage of employers have a different view. It's going to be a challenge.
One way to think about it is to simply make the right thing to do the easy thing to do. Mm-hmm. So that aligning incentives, because the incentives for patients who do have choice and who do want choice aren't always, it isn't always obvious that what the right thing to do is. Sometimes the feeling is, well, the CT scan, multiple CT scans is best for me, and so don't get between me and my multiple CT scans, and that's the American way, right?
Yeah.
So there's got to be a shift, and you can say, well, that's on the patient and that's their responsibility, or you can say, well, the system has evolved to a point where things are so disjointed and so fragmented, and the messages are so unclear that we together need to work to make this a place where patients can trust the fact that when we say too many is too many.
Right. Okay, so I'm going to switch to a slightly different angle on the PCMH. We obviously have some nurses in the audience and others who have identified the fact that there, for many years, many nurses have been coordinating care in this way. And so we have a number of questions actually on what is the role for nurses, for other ancillary providers, dentists in the patient-centered medical home concept. Most of these presentations focus on physicians. Where are the other providers? Where does reproductive health fit? So if you can comment from your perspectives. Lee.
I'll have a go at that because one of the things we found very clearly from our data and one of the things that emerged pretty clearly from the NDP was that team-based care is necessary, and without it you really don't get very far. The traditional physician-centric model is really a barrier to getting PCMH done, and the practices that can practice as a team, but physicians who can give up some control. I mean, there are cases where it's hard to even transition to team-based care because a physician won't stop trying to do things that just don't require a physician to do in any sense. The practices that do the best at practicing as a team are clearly the ones that adopt PCMH most effectively and that realize the greatest benefit, the greatest improvement in access, the most improvement in costs, etc. The hard part is figuring out how to get those practices that are still stuck in the physician-centric model to move.
Chris.
We should consider this within the aspect of transformation of the process we're talking about. I'm going to reflect quickly on a lean experience where we have primary care practices, two of them, collectively mapping on the wall their process of care for a patient with congestive heart failure. And there's all this mess from the time the patient comes to the office, through the visit, until they leave. And then there's one line back to the patient to schedule them for their follow-up visit 6 to 9 months later. And a physician standing next to me is looking at that map and he says, this is the problem, Chris. We've got 6 to 9 months in between acute care visits to help this patient manage their chronic disease, and we're trying to cram it all into a 15-minute acute care visit. So the patient-centered medical home, the care coordination piece, if there's a treatment plan developed while the patient is there, how do we further engage the patient? I think this reflects back on the previous question as well, is in between those visits, the model needs to change. The whole approach we're doing is reactive for acute episodic care, and the role of the nurses, educators, others to support the patients in following the treatment plan they've created with their physician in between those visits is a space that we have a lot of opportunity for.
Mm-hmm. Good. So an interesting question, and it sort of came out of several of your presentations, but maybe starting with David. It's the way the structure for PCMH is working within the PGIP context in particular, some practices that are on Chris and Lee's continuum have already arrived. May well be getting more of the resources because they're already performing well. They're already designated. They get the benefits because they're there. And the practices that really perhaps need the most help, they're not meeting the goals, but they don't necessarily benefit from the financial resources. How does the PGIP model deal, the PCMH model deal with that? And for the rest of you, how do you think nationally this issue is being dealt with? It's a complex question.
So in the context of PGIP, we really value the notion that just like 20 clowns can only fit into a VW bug in a cartoon, the whole population of Michigan can only fit into 100% of the healthcare capacity, not 20% of the capacity. And so we want to lift the bar for all systems within the state, not just identify the best and have products built around them, because that's not going to serve anybody's interest in the long run. So then we value improvement in quality and improvement in cost at a population level nearly as much as we do achievement of optimal benchmark performance. And so the physician organizations that are lagging have an opportunity to earn significant rewards if they're improving. So they don't have to feel left out or hopeless. Also, the initiatives that I mentioned, the infrastructure development initiatives having to do with care process and information systems and so forth, the extent to which any practice and any physician organization begins to build at the edges of their current capacity, they will get money to support that. The extent to which, even if they're lagging behind, they get ambitious and build more, they'll get more money. So we structured it so that it isn't just a have and have not situation, I think.
Jean?
So I get that question fairly frequently with this demonstration project because people around the state, they don't want to spread the wealth around rather than concentrating it in folks that are already doing well. And my response to that, which ties in with the research results that we've heard about today, is that we don't really know if this model works. And tweaking a large amount of practices probably isn't going to get us the information that we need. So if we take practices that really have demonstrated the capacity to do this kind of transformation, and we say, let's really test this model. If you put all this together in the best way you can this really improve outcomes? Can this really save money? And I think that's the question that still really needs to be answered. So that would be my rationale for doing this.
Good. Okay. So on those lines, also, Jean, a question about what would for the demonstration project, what are the measures of success? What are you looking for?
Well, as part of the application process, we had to submit an evaluation. Is Claire still here? Yeah. So we, one of the things that differentiates the patient-centered medical home from the old HMO models is this isn't just about cost saving. This is about cost saving and better outcomes. So obviously the big burning platform is saving money. But I think that, so that's part of the equation. And CMS is doing their own evaluation of, is this budget neutral? Can we actually save money? And we're going to be doing that on a state level too with the other payers outside of CMS. The second question is looking at, can we improve outcomes? And we're not going to, in 3 years, we're not going to be able to tell if we've actually done anything to improve population health. And that speaks to how long does it really take to transform the population, the healthcare population. But I think, we have good indication that the intermediate measures such as A1Cs and blood pressure control are the things that will keep patients from developing the complications down the road. So we hope to be able to measure some of those clinical outcomes as well, and also look at the team satisfaction surveys of the staff and the providers, and also look at patient satisfaction. So I think it's a blended model, and it's a major task, as Claire could probably attest to. But so we're going to look at this from multiple angles.
Great. So for our evaluation teams here, some skeptics of the patient-centered medical home claim that you have to look at each element sort of individually. In your assessment, is it possible that these elements work together? And I think Diane talked about this a little bit too. Do these elements work together as a package? And so you need to really evaluate them to do it right collectively And is it going to look any different than if we really evaluate each individual element that's part of the PCMH?
I think the NDP evaluation team put it best. The transformation is not just an accumulation of individual changes.
Mm-hmm. Mm-hmm.
Yeah, and we've thought a lot about that.
I'm alluding to the comment I made about the measures of PCMH being sort of linear and additive, and the fact that most of the research has not really looked at it from a systemic point of view. And this is just sort of habit, I think. We all kind of throw the variables into a linear regression model and see which of the components has an independent effect. And really it's sort of antithetical to the whole notion of PCMH. So I think we need to get beyond that, at least on the research side, and think of PCMH more as a system of care and start to evaluate and measure it systemically.
Yeah.
I think that emerged very clearly in our data. The practices that tried to just do the pieces, they didn't do well.
Yeah.
The practices that transformed, that had a relationship style, a leadership style, that was qualitatively different, that was better adapted to the PCMH, they're the ones that did well.
Yeah.
It's a different style qualitatively. It's not just an accumulation of pieces. It is a system change.
Mm-hmm. Diane, you want to add? Go
And
ahead.
I think you can take a practice that's doing things in sort of a traditional way, and you can give them IT, you can give them a computer. And we know that we've been doing that for a very long time, and what happens is sometimes that computer gets plugged in, and sometimes it doesn't. There's a lot of work to plugging in a computer, and then what? And then how do I use it? And then, well, I've got patients to see every 15 minutes, and how's this computer going to help me do that? And there's a huge knowledge gap there. I'm not paid to do this. I wasn't trained to do this. Thanks for the computer. It doesn't connect to the hospital. It doesn't connect to anybody else. So same thing with many other aspects. You can improve access by requiring somebody to have a telephone line where you can call a nurse. But if that's not incorporated into the whole flow of the practice, it can become useless. And so the patient, you can call and talk to a nurse, but it has nothing to do with your overall care. Or, for example, Saturday access. You can open a Saturday clinic. Many people do open Saturday clinics. And then you've got a Saturday clinic, and that lasts until people don't want to have a Saturday clinic anymore, and you close it. So, all of these pieces have been tried in many ways, but there's a transformative effort here, qualitatively different aspect to this that is saying that if we really want to get serious about this, just like we can't look at you as a combination of your knee pain and your migraine headaches and your, your hearing loss, and therefore you need these three specialists. You are a whole person, and it works as a system, and I think that's fundamental to this model. I think the idea of looking at the practice as a system is something that we're sort of moving back toward, and you can't fundamentally change and transform the practice with these sort of incremental looks.
Great. Just two specific questions for David and for Jean on the demonstration project. Maybe you could comment a little bit about how the demonstration project connects to models that are non-physician centered. There's some specific models referenced, and also to the Minnesota ICSI program, and maybe you could comment a little bit about what that is, about the ICSI. It's the well, go ahead.
Yeah, sure. I can never remember what
the initial
stands for, but
yeah.
It's a Minnesota thing that's been around for a while that helps practices improve. Started with focusing on guidelines, now has a focus on things like depression management and primary care. So helping to catalyze more evidence-based practice and more systematic practice in ambulatory care especially. And so there's a movement in the western part of the state to develop such a program, provider-led approach in Michigan. And that's great, but I don't see that in any way as competitive. Also, Jean is going to be starting a managed care care management resource center that's going to help spread knowledge about care management and self-management support and care coordination, and to help to identify models for implementation of these approaches and help support practices in their efforts to incorporate them regionally or locally. So these are examples of ways that providers organize to support organized systems and physician organizations as they elevate their level of sophistication vis-a-vis the medical home model. So as far as I'm concerned, these are just ways that practices bring knowledge and structure to the communities of caregivers in which they they exist. There was another question in there with regard to the multi-payer
Multi-share
demonstration
plan, the
But-
multi-share plan.
Yeah, I didn't understand that question, actually.
Maybe we can talk with, because this is from you, Max. You could talk about it a little bit later. It's a
Well, I think you're referring to the Western Michigan ones that have been created there and now are in about 12 or 14 states aimed at getting prepaid health care focused on health management and integration of claims data with management so that you partner with patients.
so it's
Patients become part of the partnership.
yeah.
So this is talking about examples of models that are already in the works of
Yeah.
partnering, having patients and providers partner, sharing of data
Yeah.
and so forth. I'm not familiar with that, so yeah, I'll be
Yep.
interested to hear because I can't really respond not knowing much about it. Do you know?
Nope. Okay.
So we have something to learn. Thank you.
That's great. Okay, just a few more, and we'll finish up. The Institute of Medicine has released the 6 aims for quality improvement. How does PCMH fit? Where are they different?
I love this question because I wrote a paper on it. So, in JJ last year, and really it was about, I was asked to write a paper about the outcomes of the patient-centered medical home and how we should be thinking about the outcomes. And you know, as this is, the patient-centered medical home sort of emerged and people were trying to get their head around it, and is this something new or is this the same old story? And you know, is this just managed care revisited? And it's been this sort of journey that we've all been going on. And so this issue of, well, what should the outcomes be? How should we measure outcomes? And it was the internists and academic pediatricians and internists who wanted to put together this idea, this topic, this discussion about outcomes. And I ended up with the IOM model saying, you know, this should be held to no different standard than what our goals are for the healthcare system. And if our goals are to create a healthcare system that is, you know, equitable and timely and efficient and what are our patient-centered, safe, efficient, timely, equitable, and effective, then this should get us toward that, and we should start thinking about how that works. And the interesting thing is that the reviews I got back on that for presenting it and then through the publication process were, no, patient-centered medical home shouldn't affect patient safety, so take that out of there, and patient-centered medical home isn't about some of these other issues that you've talked about. And I really feel like, no, the patient-centered medical home, it is about primary care, but it's not just about primary care. It really is a model of care that reaches beyond the primary care walls. And if we can't start thinking about patient safety in the primary care world, which frankly we haven't done much of, and that's fine, but we need to start doing that, and this provides, this transformative model really allows us to start thinking about, well, there's a gap, there's a hole. Why don't we talk about patient safety in ambulatory care? And what would be some good measures of patient safety? And how would we start approaching that? Because really, this model puts in place some continuous quality improvement, some data-driven processes, changes in roles. How can we then build into that some of these other issues? So I think it's very relevant to timely care. I think timeliness not only in primary care, but timeliness in how long are your waits to getting to a referral, how long are your waits to get your first dose of medication in the outpatient arena when your chest x-ray comes back positive. How do we start thinking of some different some different measures, and start delivering some of the more meaningful research around this to get at issues of patient-centeredness, safety, efficiency, timeliness, equitable. One of the great things about this is that you've got people, this is being demonstrated in many Medicaid, in many states in the Medicaid arena, and through the FQHCs, through the Department of Defense, through the VA. They've just adopted the model, Medicare. So this is one of the first times where we're really seeing a model span the private and public sector, and go from all the way from FQHC and safety net settings through the commercially insured and well-insured, more private type clinics. So I think that we should be getting more equitable care. If we don't, then the model's wrong, and we need to think about it.
So just along those lines, do we need more to align pay for performance, or do we not need pay for performance anymore? Should this all be part, integrated into the concept of patient-centered medical home, accountable care, et cetera? You quickly, and then I'm going to
just say that some people will say, well, why don't we just pay primary care doctors to do what they need to do? And if we pay them better to do what they need to do, then forget pay for performance. There's a whole nother world out there that says we need to improve population outcomes. And so it's great to pay primary care doctors to do what primary care doctors do and to deliver recommended care, et cetera. But we need to make medicine more accountable for delivering improved outcomes. And so there may be many, many ways to do that, and different people may approach that differently. I think primary care is going to be essential to delivering improved population outcomes. And this is a relatively new thing, but I think that we're there. We're there with accountability. We've got to create good measures, and I think pay for performance is always going to be part of that, and I think that's a reality for any young physicians out there.
All right, so I know you want to comment, but I want to do 3 predictions, and we're almost at the end. So, mini. Very short, David. Very short.
They're cruel. They are cruel. This is a side note. Pay for performance at the population level. Reward the system for achieving good outcomes, not at the individual provider level. That'll catalyze systemness, catalyze the result that you want, and avoid the problem of adverse selection, patients being cherry-picking, focusing on playing to the quiz rather than changing the system.
Okay, that was worth it. Thank you, Dave. Okay, 3 quick predictions from you each. First question. Do you think employers are going to start providing incentives? And we're just going to go down the row, yes or no, quickly. Start providing incentives to their employees to use patient-centered medical home practices. Are you predicting the private side is going to jump on this bandwagon? Or are they already?
Yes.
Yeah, good.
Yes.
I love it.
I can't say no.
The smart ones will, the ones who don't particularly care won't.
Okay.
Reliant on outcomes.
Similar answer. I think they will jump on board provided that there is evidence to suggest that it will affect their bottom line.
Okay, great. Do you think it's a good, or in this context that we're talking about, do you think it's a good or bad idea for hospitals and primary care physicians to consolidate into the OSCs? Good or bad? Just 2-word answers. Yes or no? I'm sorry, David. I'm sorry. We're into ACOs. Good idea. Merge. Yeah, well, to merge and consolidate, not just the concept of putting them together, but in a real organizational, structural ownership integration. Okay, you guys, shrug is okay. It's a big question.
Affiliate, collaborate, integrate, yes, can be done with ownership with the right leadership and vision, can be done without ownership with the right vision and leadership. And so it's sort of situational dependent.
Very good, impressive.
Yeah, I was going to say maybe, because I think it does depend on the environment and the community and how it's set up.
I'll say in only a few cases. In general, the incentives of hospitals and the interests of hospitals are different enough from primary care that it doesn't make sense for a lot of them, and would, I think, distort the system. There are a few exceptions.
The question was posed as an organizational business perspective. I don't think that's the right question. It's the process issue. It's the relation between those systems of care. Absolutely, the business model.
So he's a maybe too.
I would vote no on consolidation, but yes on alignment.
Interesting. Okay, last question. Is there any future for independent physicians, small practices, 20 or less? Question didn't ask. You can frame it that way, short or long term.
Well, I think, yes, there's a future because that's where most people are practicing. And so whether it's short term or long term, I don't know what will happen in the very long term. I think for now, that's what we have. And I think we need to all just kind of accept that and start to think about what that means and how we're going to deal with that, because we need to fix the healthcare system and make some improvements and stem costs. And that's what we have to deal with. So in the short run, yeah, there's a future.
Yes, with clinical integration and shared accountability.
So pithy.
I have to say yes. I mean, there are a lot of rural areas out there that's what they're that's their health care.
I'm going to say both yes and no. Yes, with the kind of integration and that can bring the supports necessary to practice the PCMH. No, in terms of the cottage industry that we have now. I think that the day of the standalone 1 or 2 doc shop, I think it's over.
The perspective, the reflection from all those clinics that, boy, we sure need to hear more from others. That creating that kind of community is essential to sustaining the independent practices.
I would say yes, provided that models of care can be adapted to the characteristics of those practices rather than imposing sort of a one-size-fits-all.
Great. All right. Thank you for the quiz. That was good. Thank you all for attending the symposium today. Thank you, panelists, for a great and provocative conversation, and we look forward to the future. And it will all be on our website in the near term. Thank you, everyone.